Hi, everyone. I am Jandra Mueller. I am the clinic director for Pelvic Health and Rehab Center in Encinitas, California. And today's webinar series is on endometriosis. So I have a particular interest in this topic. One, because I've been through this treatment and I had endometriosis and I had surgery last March, so March of 2018. But I just find that it's really unfortunate that I feel like many women aren't really listened to, or their symptoms get really dismissed. And there's actually so much you can do to treat this disease. So I really like helping educate other women and other providers about this condition. So what is endometriosis? So endometriosis is endometrial-like tissue which grows outside of the uterus, commonly within the pelvic and abdominal cavity. So the important thing to know is that it's not the exact same tissue as your endometrium, which is the lining of your uterus that you shed monthly. It has similarities, but it's not the exact same. One of the things that's interesting to know is that it does still respond hormonally. So when your estrogen and progesterone spikes, this tissue does grow and then it sloughs off monthly as well. The difference is that this tissue is sort of within your abdomen and pelvis, and it has really nowhere to go. Like when you have a period, it comes out of your body. So that can create some issues. So it's also an inflammatory condition, and it's hormonally mediated, and it's an estrogen-dominated disease. So this is going to be important because you're dealing with inflammation, you're dealing with changes in your hormonal status that are happening regularly, cyclically, monthly for probably many years. And it's classically an estrogen-dominated disease. So it's classically characterized by painful periods, which is known as dysmenorrhea. And then many women who suffer from infertility, endo is actually often a common cause. So some women don't have symptoms, but they have a hard time getting pregnant and they go through different treatments. And maybe later on down the line, they find out, oh, it's because there's endo. And part of the reason for that is that, again, going back, endo is an inflammatory condition. So if you have an inflammatory environment already, it's going to be difficult. It's going to be a difficult environment for you to be able to get pregnant. There's a specific type of endometriosis that we'll talk about, and that's where you have endometriomas, which are also known as chocolate cysts, that can actually deplete some of your ovarian reserve. So the eggs can be deficient, or it has a harder time for the sperm to meet the egg. But other common symptoms and what are known as comorbidities, but now they're recognized more as overlapping pain syndromes, are dysuria, which is painful urination, dyspareunia, which is painful intercourse, dyschezia, which is painful bowel movements, and then the overlapping pain syndromes, which are chronic pelvic pain, irritable bowel syndrome, and interstitial cystitis, and painful bladder syndrome. So we'll talk more in depth about each of these things, but these are sort of the classic symptoms that women with endo report. So I really liked this chart or this depiction. This is from an article that looked at GI symptoms in women with endo, but I like it because it also looks at a lot of the symptoms that we just went over. So GI symptoms, so this study was 355 women were undergoing operative laparoscopy for suspected endometriosis. So these women have not been confirmed having endo, but they tracked the symptoms before surgery. So the top symptom was GI symptoms. 90% of these women presented with GI symptoms, and you can see here in 81% of that 90%, they had a diagnosis of endo. So the way that they diagnosed endo was actually excising it and sending it to a pathology lab to confirm it. It wasn't by visual diagnosis. The second most common symptom, and of the GI symptoms, bloating was the most relevant one. So 82% of the women who complain of GI symptoms, 82% describe bloating as one of that. So that's known as endo belly, for example. And then the next symptom that was the highest was dysmenorrhea. So painful menses or menstrual cycle. 80% of women described this symptom. And of these 80%, 82% had a confirmed diagnosis of endo. This goes on for back pain, 75% of women, pelvic pain, 66.5%, dyspareunia, 63.7%, and dyschezia, 46.7% of women. So, and a lot of these women, the majority that had these symptoms did have a confirmation of endometriosis as their diagnosis with surgery. So who does endo affect? You may have seen in the last few years, there's a big push towards 1 in 10. So you've seen signs with women holding it up, I am 1 in 10, or their support system. So sometimes you see the kids, you know, my mom is 1 in 10, my wife is 1 in 10. And that's because studies have consistently shown that about 10% of women have endometriosis. There's often a delay in diagnosis of 7 to 10 years, and that's going to play into some of the pain mechanisms that we'll talk about. It can affect all women, so adolescents. It's also been seen in fetuses, and it's interesting, the amount of fetal diagnosis is about 9%, which matches that 10% that we see in our society. But it can also affect prepubescent girls, and there was even an article of a 52-year-old male that had confirmation of endometriosis. First, so women that have either a sister or mom, first-degree relative, that has endometriosis, they have a 7 to 10-fold increase in the chances that they have it as well. Endo is not a disease that affects one ethnicity or race more than the other. It's pretty much shown to affect all women equally. And going back to the familial relationship is like, this can be a good and a bad thing. So it can be good because maybe those that have had, you know, a sister or a mom that's had adequate treatment, they can recognize it early on, and maybe it helps in that delay of diagnosis. But it can actually go the other way too. You know, a lot of times women will complain of like really bad period cramps, and it's so normalized in our society that, you know, if you talk to your mom when you get your period and you're a teenager and you complain, and your mom had the same experience, and her mom just told her, oh, it's, you know, I had it too, this is just what it's like, you start to feel like this is normal and this is what should be happening, and you don't really seek treatment. I think just now we're really starting to recognize that this is not normal. It's not normal to miss school. It's not normal to miss work for period cramps. And so I think it can go both ways. Additionally, just the delay in diagnosis of 7 to 10 years, that's a lot of your life that's going to be impacted, especially if you started having symptoms at maybe 12 or 13 years old. That's a lot of your adolescence, that's maybe your college years or early 20s, and there's a lot of things that you might miss out in that time. So how does endo develop? There's a lot of theories about endo and how it came to be. Many of them seem logical. Some have been disproven, or other theories seem to make more sense. And there's some debate about it, but we can pretty much safely assume that it's probably a combination of these reasons. The most recognized theory is Sampson's theory of retrograde menstruation. So this is maybe what most people have heard about. So the thought was that during menstruation, the endometrial cells are flushed back through the fallopian tubes and into the pelvic cavity, where they then implant themselves on other tissue. And then they grow because they're hormonally dependent, and they create inflammation and all of that, which we'll go through more in depth. But we know that endometrial lesions and the endometrium, although they're similar, they are different tissue. And also a study showed that like 90% of women have retrograde menstruation, but out of these, maybe only 15 develop endo. So that theory has sort of been kind of disproven to a sense. But then due to advances in technology, there's also changes in these cells that suggest alternative theories. Like one is called metaplasia of mesothelium. A lot of big words. So this is basically where one cell changes or develops into another cell. And this is maybe why there is endo that are found in other places like our joints. Coulombic metaplasia is somewhere between, lymphatic transport. So they think that maybe some sort of stem cell, which is another theory, go through the lymphatic system, which is a transport system for our body, and then they start to implant themselves that way. So like in the lungs or the brain. So then the coulombic metaplasia is somewhere between those two theories, in that the tissue develops when you're an embryo into the covering that then lines the abdomen and some of the reproductive organs. And then I went through the lymphatic and the stem cells, and then embryologic, like I mentioned in a previous slide, they have seen endometriosis in fetal tissue, which matches about the same percentage that we see in women today. So they think that there's already lesions there when you're born, and why they develop and become painful or problematic, that is in part due to our genetics and what's called epigenetics, where under the right environmental circumstances, a cell that may not develop into anything could then develop into these endometrial lesions and create dysfunction and pain in the body. But that, I think, again, going back, it's multifactorial. So we can't say that any one of these things is exactly why, but it's things to consider. And then our environment really plays a role in whether we experience the problems that these lesions can cause. So how do you diagnose endometriosis? So there's a clinical diagnosis, but then there's also a surgical diagnosis. So the surgical diagnosis truly is the gold standard. So excision of a tissue, so a biopsy, that is sent to a pathology lab, where a pathologist then looks at it under a microscope and identifies it as endometriosis. That is truly the gold standard for diagnosing. But before you even get to that point, many of you watching, if you have endo, have probably been clinically diagnosed. So this basically is, you go to your doctor, you tell them what's going on, you tell them your symptoms, and they say, okay, you probably have endometriosis. They may do a physical exam if they're a specialist and look for different points in your body where endo tends to sit. And there has been some studies to link with a type of endometriosis called deep infiltrating endometriosis. There has been some linkage to certain areas and certain physical exams that can potentially say that, yes, you may have endometriosis. Some doctors will use imaging techniques, but if you don't get a positive finding, it doesn't mean you don't have the disease. Some types may show up depending on the type of imaging you get, but it's not a conclusive way to diagnose endo. The other thing too is that some women undergo what's called a diagnostic laparoscopy, where the surgeon goes in and they just look around, and then they either say like, oh, we didn't see anything, or we saw some lesions that look like endo. That can be inaccurate both ways. So if somebody has that and you've seen your just typical OBGYN and they've said, we really didn't see anything in there, it doesn't mean you don't have it. It could present very different ways. And that's why the gold standard is the surgical excision sent off to a pathology lab. So the locations of endometriosis can appear in many places. So it can be in the pelvic cavity and the abdomen. So those are the most common sites that you'll see endometriosis. So the pelvic sidewalls, the covering, which is called the peritoneum, And then endo can also attach itself to the pelvic organs, the bowel, the bladder, the intestines, the rectum, the appendix, ovaries, fallopian tubes, ureters. Those are the pretty common sites. Sometimes they'll go in and they'll look at the upper abdomen and the diaphragm, the liver, the abdominal wall, the perineum, which is part of your pelvic floor, and then also the thorax. So like diaphragmatic endo or thoracic endo are pretty rare, but they do happen. And then the endo looks like typically like blue, black lesions, which are called powder burn lesions, but also red lesions too. But that doesn't mean that that's it. So there's also been endo that's appeared clear as like clear vesicles. There's red, there's yellowish brown, there's white, and then there's lesions that appear like scars or fibrotic lesions. So the three primary pathological types, so there's red or petechial implants. So these are the most active lesions. They produce what's called prostaglandins, which are inflammatory mediators. So the cells produce these inflammatory chemicals, as well as endometrial proteins and different hormones. So the lesions actually themselves produce estrogen, aside from your ovaries. So the lesions themselves produce estrogen. And we talked about in the beginning that endo is an estrogen dominant disease. You can then have brown or intermediate implants. So these are moderately active and a precursor to what's called powder burns. And then you have the black or brown powder burns. And these are inactive with little cellular material, but they are associated with adhesions and stretched organs. They have nerve damage, and that's caused by like the breakdown of them, and then just each lesion has their own blood supply, so it's sort of it's called ischemic, and so it loses that blood flow, and then these lesions can actually adhere structures together. The other thing I want to mention here is that you can also see like fibrotic endo, which is a white tissue, and that is also thought to be sort of old endo. It's not the red and active where it's still producing all these things, but it still can cause issues. So the subtype or the types of endometriosis, you have 3 types, and this is important to know because there are different ways to diagnose and treat or manage these. Some differences. First, you can have superficial disease, which is typically found on what's called the peritoneum, that covering of the abdomen and organs. This disease isn't thought to infiltrate that tissue deeply, so it's just on the surface. This is what they would consider as a mild disease if you're using the staging system. And with superficial disease, there is some evidence to justify ablative techniques. That is a form of surgery that we'll talk more in depth, and there's a lot of debate about. Then there's ovarian disease, or what's known as endometriomas or chocolate cysts. So this is often found on the ovaries, and some imaging techniques can actually pick up endometriomas, so transvaginal ultrasound, MRIs, and this really, you can see a problem with fertility and ovarian reserve in women that have endometriomas. Also, these can recur even after surgery. So a lot of the thought between like excision or ablation surgery, unfortunately with endometriomas, these can recur pretty frequently after a successful surgery. And then you have the third type, which is deep infiltrating endometriosis. And remember, in all of these, you can see these different forms of endo, the ones that we just reviewed. So this is important because when it comes to surgery, if you burn the lesion, you're only burning the tip or what's on the surface. So you don't really know if you have superficial disease or if you actually have deep infiltrating disease unless you actually cut out the tissue until you see healthy tissue and it's examined. So deep infiltrating endo is usually classified as greater than 5 centimeters, I believe. And like I said, you won't know that unless you cut it out. So if your surgeon has gone in and just burned lesions and said, well, I saw that it was endo, they don't know if that was truly endo, and they don't really know if it was superficial disease or if it was deep infiltrating disease. Deep infiltrating is typically found in some of the more deeper tissues like the uterosacral ligament and the cul-de-sac, whereas superficial disease tends to be just on the peritoneum, but you don't really know, and that's just, you're going on the surgeon's like visual, being able to visualize the lesions at that point. So I want to talk about the staging of endo for a little bit. I think people get a little confused when they hear like, oh, I have stage 4 endo, or I only have stage 1 endo. The staging system was developed by the American Society of Reproductive Medicine, and it was actually intended to determine fertility outcomes of surgery. So women undergoing surgery to improve fertility, this is why the staging scale was implemented. They tried to correlate it to patient symptoms, but there's no correlation between the stage of disease and the pain severity or the pain that one experiences based on the stage. So I have a lot of patients that will still come in and say like, oh my gosh, I have stage 4 endo, it's really severe, but like maybe I don't have all these other symptoms. Or I have somebody that's like, yeah, you know, they seem disappointed because they said, well, I went in and I only have stage 1. Well, that's because the staging system is not meant to tell you your symptoms are mild or your symptoms are severe. It's now just more used as a formality to help surgeons kind of report where they found the lesions and like how deep or how extensive the disease was in when they visualize it. So stage 1 is going to be minimal and few superficial implants only. Stage 2 is mild, more, and the implants are deeper. Stage 3 is going to be moderate. There's a lot of deep implants. There's small cysts on one or both ovaries, and then presence of filmy adhesions. So that's where you're starting to get into seeing some of these different types of adhesions. And stage 4 is severe. There's many deep implants. There's large cysts on one or both ovaries. So this just helps surgeons document what they've seen. So this is actually a sample operative report. And this is some of the language you might see when you read yours, if you get it from the doctor. And I thought it was important to point out because it's a lot of big words and it can tell you a lot. So here, sometimes they'll document on what the uterus looks like. So globular uterus. Adenomyosis is another condition that sometimes can coincide with endometriosis. So it's endometrial cells within the muscle layer of the uterus. So it's not outside of the uterus, it's inside. And this often can only be diagnosed. I mean, sometimes you can diagnose it with MRI, but usually it's you have to take a uterine biopsy or you have to, once you have a hysterectomy, they can test the tissue. But there's some changes that can look like adenomyosis. So they comment on that. They comment on the uterosacral ligament, so thickened and fibrotic. Fibrotic can be one of those terms that you see that denotes endometriosis. Sometimes they'll talk about the increased vascularity. So we'll talk about in a little bit, but each lesion can create its own blood flow. And so sometimes you'll see areas, and this is very much dependent on how much experience your surgeon has, but they can talk about increase in blood flow to a certain area that's maybe not exactly normal. But that is, again, that's based on your surgeon's experience of seeing many of these women with endo. They can show like thick and fibrotic. This just means there's a lot of redness around the peritoneum, and that's a common location, the left ureter. They'll comment on the ovaries and fallopian tubes. Clear vesicles, that's another one of those types of endometriosis. So they're commenting all of this, and they're taking it out in excision surgery and sending all of these tissues to the pathology lab to test. So pain. This is the big question with endo because honestly, some women don't have any pain and they happen to go in for some surgery later on in life and for some other unrelated reason. And the doctor is like, wow, you had endo everywhere. But they come out of surgery and they're like, I never had pain. So pain is really an individual subjective experience that is complex and it involves the nervous system. Therefore, endometriosis must affect the nervous system at some level. So we know that endo is an inflammatory condition and it's hormone dependent. The exact mechanism is not fully understood, but it's likely a combination of both local and systemic factors that are going to influence both your peripheral and your central nervous system. And they have a somatic and a visceral source. So somatic is like your muscles and your skin, and visceral is your organs. There can also be a couple types of pain. So one is nociceptive pain. So that's the pain where there's like temperature, pressure, that are sending signals to the brain and creating a response. And then there's neuropathic pain. That's where our nerves are getting sent messages all the time. And over time, they maybe increase their nerve endings or they start sending messages back to that tissue that further create this pain response and then become very sensitive to any sort of stimulus. So all of these can be what goes into the development of pain for women. So pain is helpful to keep us out of danger, but sometimes the things that may not be dangerous are processed as dangerous. So that's going back to that neuropathic pain. It's sort of an alarm system. We need pain because that helps us, remove our hand from a hot stove. But depending on your experience with pain, or if you've had pain for a long time, the system starts to become more sensitive to it, so your body reacts more, even if it's not a really dangerous issue or source of stimulus. But it's just an alarm system that is going off even though you don't want it to. So when we talk about the peripheral nervous system, we talk about all of the nerves that are outside of our brain and spinal cord. And they can be sensory nerves or motor nerves. And then you have your brain and your spinal cord, which are central nervous system. So this is sort of a pathway of information of stuff that's getting sensed in your body and then going through the central nervous system to your brain, so your brain can make sense of everything that's going on and then send messages back either to further say, like, this isn't going away, we need to be on hyper alert, or it's going to say, I'm not really, this is, I can't deal with this right now. And it's going to send inhibitory signals so that you don't really feel it. And this system works together and is influenced by a lot of factors. So again, it's a good reminder that not all women who have endometriosis experience pain. Going back to the development, they may have the cells in their body, but maybe they've had very little inflammation or stress, all these things that can really upregulate our nervous system. And they just have gone through life and not really experienced that, they're very lucky at that point. But then there's others that, they go in and they get the stage 1 endo and they have one little lesion and they're on the floor every month, can't get up, can't go to work, can't go to school. And it's very real. But every experience and every person is different in how they're going to react to that. So talking about the development of lesions and pain. So it's important to understand how pain is created by the endo lesions. It's important to know how the lesions develop. So this picture there's a lot going on actually, but it really shows kind of the progression of the lesions and what's going on. So this would be an example of one of those red active lesions. So from whichever way it got there, it's now implanting itself on tissue. So once it implants itself, it actually starts growing in blood vessels. It's growing in nerves to be innervating. And there's a part that the immune system is involved. And so normally, like when when there's cells that are really normal in our body, our immune system kicks in and it can like bring in factors that destroy those cells, or some of our cells undergo what's called apoptosis, where they just like, it's not normal, it destroys, and we never see the effects of it. This is happening in our body all the time. Unfortunately, for women who have symptomatic endometriosis, these things aren't happening. And what's happening is these lesions are implanting, they're growing their own blood vessels, they're growing their own nerve innervations, and they start producing factors that create issues and low-grade inflammation. And they're also producing estrogen. And then they're going through their life cycle, they're responding to increases in estrogen. And if you're not on oral contraceptives, you're getting differences in estrogen throughout the month. So it spikes, these lesions are going to grow, it goes down, these lesions are going to start to break down, and it goes like that in a cycle. So these cells can then grow, and they can actually put pressure on nearby organs or nearby nerves and other organs. And then they can create more nerve endings, and they're sending all this information and chemicals that they're creating to pain nerves that are going into your spinal cord and then up to your brain. And then your brain is actually sending information back down to the lesion and promoting more inflammation. So this whole cycle is going, and you're just creating this really low grade inflammatory response in these lesions. So once this process starts, it's ongoing. And so as you start to go through your cycles and these lesions are still active, the more estrogen that's being produced is going to then further sensitize your nervous system, and you're gonna appear to have more pain than what's really going on. That's part of the central nervous system sensitivity. So it modulates pain, and there's studies that look at sex differences in pain, and in women who have cyclic pelvic pain, they don't even necessarily have endometriosis, but they just have monthly pain, and they've done tests where even like something as light as a light touch or heat actually generates pain in these women, and that's because of these processes. And then as the life cycle of these lesions go on, you can see they start to develop like more like fibrosis or scar tissue. So they're not as active, not producing the same chemicals anymore, but they can also adhere organs and have this low grade inflammation still. One of the other things that this doesn't quite mention is endo has been related to like mast cells. So mast cell is another type of cell that's lining any tissue that really has factors that are exposed to the external environment. So your gastrointestinal system or lining, your lungs, your skin, they all have mast cells, and mast cells can produce inflammatory chemicals also, and histamine. So there's been a lot of studies that look at coexistent conditions like asthma and endometriosis, or like we'll talk about later on, these overlapping pain syndromes like chronic pelvic pain and IC, painful bladder syndrome. One of the theories also is that it's a mast cell generator, creating a lot of histamine, which your body reacts to. So this is an article that's by Stratton and Berkeley, and it's actually a free article. So you can get this, and it's a really, really great overview in general of endometriosis and the treatments and the pain pathology and pathways. But this just goes and it puts a better picture of what I just described earlier. Is you have this lesion down here, and you can kind of see that this would be like those powder burn lesions, and you have information coming up into the spinal cord. This would be like your lumbar, or sacral vertebrae, sacral discs, lumbar, thoracic, cervical, and then your brain. So you have this information coming up to one segment, and it's going to travel up all these different segments into the brain, and the brain uses all different areas to make sense of this information. So going back, if your mom is like, no, this is totally normal, a center of your brain might be like, this is normal, this is just what it is, and kind of dismiss it, get through your day. You might have no idea, and it might be so scary that you're like, this is so much pain, and your brain centers start to go into more protection mode, and maybe you are somebody who has way more pain. The other thing to note here is that as it goes up into each segment, what you're not seeing here is that it can connect and then come back into these little nerves that are in each of your segments and then go back down to the tissue. So it can address multiple levels. And if it's connecting to a nerve that then goes to your bladder, for example, you might start getting symptoms in your bladder. Again, this is a process of what's called central nervous system sensitivity. Everything's becoming heightened, and that is something that's called visceral hypersensitivity or organ crosstalk. So why do so many women have bladder symptoms with endo? Why do so many women with endo have GI symptoms? That's in part due to this overlapping of nerve innervations and multiple organ involvement, because you're getting this heightened response and it's then coming back and going into different organs. So the origination of the disease might not be that organ, it might be this interplay of the nervous system. So again, this is a free article and it's a really, really, really great article. So how does pain develop then? I just told you all these theories. So pain can be created by the lesions themselves. So they're producing inflammatory mediators, they're sending them to the nervous system. It's creating low-grade local inflammation. There's also the pain created by lesions. It can be compressing like nearby nerves. And then that whole process of the nerve going up and sending information to the brain and the brain sending information back down, and your body getting more sensitized to that, that's called peripheral sensitization. So the actual nerve endings in the lesions themselves are maybe either growing and sprouting, or they're just becoming more reactive to the same stimulus. Then you have the central nervous system sensitization. So that's where it's kind of like an amplifier. It's an alarm system. Your brain is like, this is not good. There's a lot of fear involved, and your whole system now is upregulated. Same stimulus, but much heightened response. And then you have the organ crosstalk, or what's called visceral crosstalk. That's where the nerve goes into the spinal cord. It maybe goes up a few levels and then comes back down onto the other organs that are being innervated by that nerve. And you're seeing problems or symptoms of now this other organ system, like the GI system or the bladder, where the issues aren't arising there, but they're being affected because of this nervous system involvement. So this is just for people that are more visual. I liked this little graph. So you have pain caused, again, from endometrial lesions, peripheral sensitization, compression of the lesion on nearby tissues, estrogen modulates pain, and then your central nervous system can create central sensitization. So that was kind of the recap. So everything we've discussed so far, which was a lot, pain science is pretty complex, is the main points I would say is that the extent of the disease does not correlate to pain severity. So stage 1 disease, you could still have 12 out of 10 pain on your pain scale. It's just a way that the surgeon is documenting their findings. Pain is a complex process that is different in everyone, and it can be generated from multiple sources. The longer that you have pain, the more involved and complex the pain generators can be. So now you can start getting multiple organ systems involved. And it's important to find and treat all pain generators to fully address endo. So I can't really stress that part enough, because I see so many times that women are, lucky enough to get in and get a clinical diagnosis, but they have all this stuff going on and they go in for surgery and they come out, the pain's unchanged or they're worse. And they've had a successful surgery, meaning that all the endo has maybe been excised. But it's because there's other pain generators that hadn't been addressed prior to surgery. And I think that's really important to note, is that you have to actually address all of them. So how do you treat endo? So there's two approaches. There's conservative approach, and then there's a surgical approach. Everyone has a different experience with endo, and despite the similarities that are there, because there's so many systems involved, it is important to take a multidisciplinary approach. So multiple providers that are working together to treat this disease. Studies have shown that women who are managed in an interdisciplinary care setting or multidisciplinary care setting do have better outcomes in regards to pain. In an ideal situation, one provider can treat everything, but that's not really reality because of the way our system is set up. So a center that offers multiple of these things is great. Functional medicine and integrative doctors tend to have it. That's really where it's becoming more practiced, but insurance doesn't cover that. So it's not really the reality right now, but that's the ideal situation. And I think it's important to know, like, whether you choose to have surgery or not, it's important to know the various ways that endo is treated. I always tell my patients that it's their choice which treatment they choose. Some people can't afford the right surgery, or some people don't want surgery and they want to do things naturally, or some people, all they really care about is symptom management and they choose a treatment based on that. And I think my role in helping these women are to educate about what that means. So are women, that are taking birth control pills, some of them think that's what's going to treat their disease, but it's not. It's really symptom management. And I think more than anything, informed consent is the best option. Because if you're thinking you're doing these things and it's curing the disease, that's very different than taking it because your number one goal is pain relief and you don't want surgery. So I think it's just important for people to know what each treatment is targeting. The other thing is that they think like, oh, well, I had surgery and I'm not better. And why is that? It's helpful to know how these things are managed. So the American College of Obstetrics and Gynecologists, which is the governing body essentially for OBGYNs, they state that medical management can improve symptoms. It should not be used to diagnose endo. So this is, for example, like if a woman comes in with painful periods and is prescribed oral contraceptives, it's important to know that if that woman gets better, that doesn't mean she has endometriosis or vice versa. Again, going back, surgical excision with histology is the gold standard. Medical management is also not shown to be effective in preventing disease recurrence nor improving fertility. Medical management is only palliative in nature and may help to suppress symptoms for some patients for a period of time. So basically this is saying like you can take it and it may help some women for a certain amount of time. It can be good for a certain amount of time and then not be effective at all. And if you stop taking it, the likelihood that you have symptoms is going to continue. And then there's also a lot of like suppressive therapies that had been used to see if this could improve for infertility. But in 2007, there was a Cochrane review that said that it was not effective in doing this. So conservative treatment the goal is pain or symptom control. And you can use medications like NSAIDs, so ibuprofen. Many women take ibuprofen monthly. There's actually some studies that are coming out, and in the integrative field, is thought to actually promote more gastrointestinal permeability, which we don't want, because that can further cause some of this low-grade inflammation and contribute. So you think you could take it for menstrual cramps and it helps the inflammation, and for some women it does, but it can also be creating or further worsening this bigger problem. Neuromodulators are used. So these are medications that help with central nervous sensitization. So some women will go on like gabapentin is one of the most common ones, Cymbalta, amitriptyline. There's various ones that can affect different parts of the nervous system to help control and mediate that. Those work for some people, but for some people they don't, and they do have side effects like drowsiness and fatigue. And you have to often be on them for a good amount of time. You have to be working with somebody who gets you on them the right way, gets you off of them the right way. And again, it's just one part of the treatment. It's not one thing that will do everything. I think the most common that most people are probably familiar with are hormonal therapies. So you have oral contraceptive pills, and there's a ton of different ones, the mini pill, different combinations of estrogen, progesterone only. And these are used to really, like, they can be used continuously where you never have that break, or they can be used just like normal. And sometimes it can take, trials of different ones, but again, they don't go without side effects. So there's psychological side effects. Some women get really depressed or moody, or they think they're crazy. Some women will have, oral contraceptives can also affect the gut and nutrient absorption, which we can get into in a little bit later when we talk about diet. So there's certain supplements that you'll want to supplement with because your gut isn't really absorbing them anymore. And they can also affect gut. They can create gut sensitivities, which then again, if you have gut symptoms and you have endo, that can further worsen that. But for some women, they're very effective in controlling pain. GnRH agonists, I spelled that wrong, but these are like your medications like Lupron, or now more people are hearing about Orilissa. These I would very much caution you to get a second opinion if your doctor's offering that. Sometimes in some women, they are very effective in controlling pain, but you can only do them so often because they create these huge side effects, and you often need add back therapies of hormones. And they can create some pretty severe issues, like bone density problems. And I think both of them have issues with like psychological effects, depression, suicidal ideations. And again, it's not going to treat your disease. Some doctors will want you to go through a round of this before they do a surgery. Sometimes you'll hear that to sort of dry up the endo so they can go in and it's less. But I would really caution this, especially if you're really trying to treat your endometriosis. I had a patient that really wanted to, it really helped for her, and she wasn't concerned about fertility. And it was the one thing up to that point. She was like, I just decided to do it again because it significantly helped my pain. But just like ACOG says, is medical management is not going to treat the disease. It's just going to help treat the symptoms, and only for a prolonged time, or for a specific amount of time. And then conservative treatment also is referral to other specialists. So that's getting back to that multidisciplinary approach where, you might be sent to a gastroenterologist or a urologist or a pelvic floor physical therapist or acupuncture or pain psychology. So this is that multidisciplinary approach to start to treat all the pain generators. Surgical treatment the goal is to reduce pain, recurrence rate, improve fertility without compromising ovarian function. So you have the two types, deep excision and ablation. I put in here hysterectomy with a line crossed through it because hysterectomy is not a treatment for endometriosis. There can be instances where hysterectomy is appropriate. That is an individualized discussion with your surgeon. But for example, if you have adenomyosis and you're really not concerned about fertility or wanting to have kids, that may be something that you should consider and could be appropriate. But many women have significant pain and they may have had multiple surgeries, and finally the doctor says, let's do a hysterectomy. That's not going to be a cure for endometriosis. So ablation versus excision. I think this is a pretty hot debate, but I think it's really crucial for one to understand the differences between them and why some people get better with ablation, why some people need excision. I think it's a very crucial part to know about if you're talking to your surgeon or you're seeking consults from surgeons, to know the language and what they're actually doing to you. So you really want to know, and you want to ask your doctor, what do you do when you go in there? Do you cut out all the endometriosis, or do you use tools that burn it? You have to ask your doctor what they do. Some doctors do a mix. They're like, yeah, we cut out, but then we'll burn. And you really, that's important to know. Especially because you may not end up with the outcome that you're thinking of going into. And if that is the case and you don't get better, you want to know, okay, well, I had ablation, so I'm not better. Let me seek out a excision specialist. So ablation uses tools that use heat energy to destroy or burn the abnormal cells. So they go in, the lesions are visualized, and the doctor says, okay, that's where it is. They use the instrument to kind of like vaporize or burn the tissue. The issue with this is that you can't obtain a specimen to send to the pathology lab for them to test to see if it was endo. So then the diagnosis solely relies on the surgeon's report, which is not as accurate as a pathology report. The other issue with this is that even though superficial disease tends to be visualized in certain places and deep in other places, you'll never know if you had deep infiltrating endo if they just burn. Because essentially, if it is infiltrating the tissue, you're just burning the top, but the lesion is still active inside the tissue. And so you go in thinking, oh, I had a surgery for endo, they got everything, and then your symptoms are better, and you go to another surgery, maybe you find an excision specialist and they cut out, and it's because you had deep infiltrating endometriosis. So those are important things to know. The other thing with ablation, though, is that there is some literature to suggest that for superficial disease, it can be effective. And there are women who, I know people personally in my life that said, I had a surgery and it worked and I was fine. And that could be because they truly just had superficial disease. So it's just important to know, especially post-surgery, if you are not better and you had an ablation surgery, don't keep going back and getting ablative surgeries. Seek out an excision specialist, because that's probably what happened. So excision is where abnormal cells are actually removed. The tools still use a heat energy, but it cuts out the affected tissue instead of burning it. The advantages to this is that they're able to send it off to pathology. They're able to see the depth of the disease. And deep infiltrating endometriosis requires removal of endo to properly treat the disease. They can also be more precise. The disadvantage is that it requires more skillful techniques and trained surgeons, which are often more expensive. You may find it hard to find a surgeon that's in your network that truly does excision surgery. It's not, it doesn't mean you can't find one, but a lot of the times they're out of network, or you have to work hard. If you have like an HMO, for example, if you're in Kaiser, you may have to really be an advocate for yourself and fight to be given like an out of network referral so that you can get your surgery covered. So what does the research say about these surgeries? So excision seems to be superior for significantly reducing dysmenorrhea, dyschezia, and chronic pelvic pain with a non-significant reduction in dyspareunia. So that doesn't mean it didn't improve that. It just, in the studies that they showed, which are limited in size and have some errors in them, they just showed that both ablation and excision helped dyspareunia, and they didn't really show like a significant difference between the two, but both helped. But you'll see in many of the articles that talk about this is all of it, even if it didn't come to significance, which in the medical world, that's what we use to say that, okay, there's truly a difference. it still errs towards that. So the trend is towards excision being superior. And that goes back to the reasons that I mentioned earlier, is that you just don't know the extent of the disease without actually taking it out. They also find that you can't burn the lesions if your organs are stuck together. You actually have to remove that, and that involves probably like a colorectal surgeon or a urogynecologist in the surgery as well. Yes. So moving away from the diagnosis and the treatments of endo, let's talk a little bit more about the overlapping pain syndrome. So this is maybe once known as like a comorbid disease, but now they know that these are all different diseases, but when it comes to endometriosis and your symptoms, it's probably not a different disease. It's just a manifestation of the same process in different organ groups. So I think it's helpful to know that, because you might not want to see 10 different providers that are all only looking at their one approach to this disease, like a urologist for IC. They may want you to undergo a cystoscopy and do all these medications, and then you're seeing a gastroenterologist for your IBS, and they want you to do all these things. It's important to know that all of these conditions share the same mechanism for pain, essentially. So, so how do you treat this, basically, and what are these? So if you have endo, and you're like, oh yeah, I actually do have IBS, or I have gut irritation, constipation, diarrhea, or I do have pain in my bladder, or it's, I run to the bathroom all the time because I have a small bladder, or I can't tolerate certain foods, and I'm having painful intercourse. These aren't uncommon, actually. And you may have never thought to put that together, but they all are involved in a similar way. So I see interstitial cystitis / painful bladder syndrome. So the definition of this is an unpleasant sensation, pain, pressure, or discomfort perceived to be related to the urinary bladder, associated with lower urinary tract symptoms of more than 6 weeks duration in the absence of infection or other identifiable causes. This is the AUA's treatment guidelines definition. So it used to be thought of as an inflammatory condition that originated in the bladder, but now it's believed to be a manifestation of abnormal processing of sensory information related to the genitourinary tract, resulting in bladder and pelvic pain and voiding dysfunction. So that just means that it's the nervous system being sensitized, or like we said earlier in that process, if you have endo, those lesions kind of coming back through the spinal cord and then hitting all the nerves that are in the surrounding area. So same mechanism of it essentially is the same way that endo develops pain, is how IC develops pain. So is it really an issue of the bladder, or is it just because there's chronic low-grade inflammation sensitizing your nervous system and then overlapping with the bladder? So there's a lot of evidence that that there's an overlap between interstitial cystitis and endo, and it's referred to as the evil twin syndrome. So you could see how these two diseases or conditions have a significant overlap. So symptoms of IC, painful bladder syndrome: urinary urgency, urinary frequency, painful urination, pelvic pain, dyspareunia, IBS. Symptoms of endo: dyspareunia, abdominal pain, pelvic pain, painful urination, urinary frequency, IBS. So it's, is it really a different condition, or is it just a manifestation of the same disease process? So in this study by Chung et al., they looked at patients with endo, they looked at patients with both endo and IC. They found that in 134 patients that were diagnosed with endo, 86% of them were also diagnosed with IC. So what they did with that is endo was confirmed by Excision and sent off to pathology to test for the endometrial cells. And then they did a cystoscopy where they put a camera into your urethra and they look at the bladder. Melinda does a really great overview of what interstitial cystitis is. And so to get more specific information, I would encourage you to watch her webinar. It's really good. So then in 159 patients with IC, 72% of those were also found to have endo. So, you know, there are the outliers that maybe they truly do have what's true IC. But in the majority of these patients, it's probably the same underlying mechanism that's going on in both these diseases, and there's just overlap in them, creating these symptoms. And then in all the women, in 69% of all the women looked at, they had both endo and IC. So going back to this overlap in the chart. So what I think is really important is that these, you know, again, are a common manifestation of both inflammation and our central nervous system being really sensitized and creating this overlap of nerve input and sensitization. I mention that because you may be being sent to multiple providers, and each provider is going to have their own way to treat each condition without really knowing that there's this central mechanism that's common in both symptoms. They also noted, and we'll get into this in a little bit, that there was an estimated like 85% of patients that presented with interstitial cystitis or painful bladder syndrome had hypertonic pelvic floor dysfunction. So that's going to tie into the next overlapping pelvic pain syndrome. And so it's just a good reminder, you know, when you're going to see different doctors is, you know, question like what their approach is and ask them about, you know, have you seen patients that have both of these things, or how do you, what is your success rate? Because a lot of the times doing the medications that they offer for interstitial cystitis or offering you a diet may not be effective for your particular case. So again, what I just mentioned, so in a study, they found that myofascial pain and hypertonic pelvic floor dysfunction coexists in 85% of patients that have or have been diagnosed with IC or painful bladder syndrome and other chronic pain syndromes. So of these, levator ani pain, so the levator ani is the deep layer of your pelvic floor, 87 to 94% had this issue. Vulvar pain, at least half. Sexual dysfunction and dyspareunia, almost 3/4 of women with IC. So you can see that there's other things going on that also need to be addressed. That's not going to fall into the standard of care for IC. So chronic pelvic pain, that's a pretty vague term. So it's defined as non-cyclic pelvic pain lasting for 6 months or longer and whose severity leads to medical care or functional disability. So it affects about 9 million women in the US, and 40% of laparoscopies and 10 to 12% of hysterectomies are due to chronic pelvic pain. So this is, you know, maybe those 40% are going in, they find endo, or it's just like severe pain that the doctor's like, let's take out the uterus. That makes sense because it's it's the major gynecological organ in there. But that's not really effective treatment, and there's other reasons for chronic pelvic pain. So in another study that was done in 2007 in patients with chronic pelvic pain, they kind of said, is it endo or IC painful bladder syndrome? So 80% of patients that had chronic pelvic pain were diagnosed with endometriosis. So the majority of people with chronic pelvic pain, endo is probably one source. In another study, again, almost 80% of patients undergoing hysterectomy for chronic pelvic pain were also diagnosed with bladder dysfunction consistent with interstitial cystitis. So almost the same amount of percentage of people were diagnosed with both conditions, that had chronic pelvic pain. So you can start to see there's a lot of overlap in these conditions. So chronic pelvic pain also can be vulvar pain. So any pain within the vulvar tissues, also known as vulvodynia. It can be described as pressure in the rectum or vagina. It can be urinary symptoms like urgency, frequency, or painful urination. And it can be dyspareunia, superficial or deep dyspareunia. So the dyspareunia is interesting with endo too, because endometriosis can have lesions on the uterosacral ligament, or it can make the cervix not very mobile. So if you're experiencing deep pain with intercourse, it could be due to both. But it can also be due to hypertonic muscles in the pelvic floor or trigger points in those muscles, and every time they're getting hit, they're referring to that area. Superficial is a little bit different. It can still be due to tight muscles in your pelvic floor that can contribute to chronic pelvic pain. But one issue, especially relevant for women with endometriosis, is birth control pills or systemic birth control can cause changes in the vulvar tissue, and it can sensitize the tissue that's outside of the vagina, and it can become really painful. This is called vestibulodynia, and it can be a result of taking oral contraceptives. And this varies in women. There's some research looking at like a genetic predisposition, but I see so many women that experience this, and it's due to the birth control pill, which is for some a very effective treatment for symptoms for women. So there's differences in the mechanisms, which is going to change how you treat this. So IBS and endo. IBS is a functional bowel disorder where recurrent abdomen pain is associated to defecation or a change in bowel habits. So the way that IBS is technically diagnosed, it's recurrent abdominal pain, on average, at least 1 day per week in the last 3 months. It's associated with 2 or more of the following. It's related to defecation, there's a change in the stool frequency, or there's a change in the stool form. So diarrhea, constipation, 1 time a day, 1 time a week, anything. So it's pretty vague. So the chart that I showed in the beginning of symptoms is that in those patients undergoing surgery for endo, 90% had GI symptoms. And I think this is a really often overlooked symptom of endo. But so many women can have this. And for my personal experience, most of my symptoms were all GI related, and it started from when I was young, like before I even had a period, really. And you undergo all this testing for GI stuff when really it was the endo going back, like creating more of an inflammatory environment and changing your gut and creating more inflammation in the gut. So this is probably starting to sound familiar. Endo is a low-grade inflammatory condition that's maintained through multiple factors, one being gut dysbiosis and intestinal permeability. And IBS is also characterized by low-grade inflammatory state that is affected by gut dysbiosis and intestinal permeability. This just reiterates what we just talked about also with IC, is that you have this activation of mast cells. Mast cells I talked about are the cells that line all those tissues that have some contact with the outside environment. So this is going to create a lot of like inflammation response and histamines, which you take an antihistamine when you have like sneezy, you have sinus problems, same thing. It's going to create peripheral sensitization, possibly central sensitization. The permeability, so what's called leaky gut, is those cells then upregulate, and there's spaces between cells where more stuff that shouldn't be going through can go through and enter our bloodstream, which then creates a whole nother immune response for our body to fight off these invaders. So I want to reiterate that it's important to identify and treat all the pain generators for a successful outcome. I can't tell you how many times I've seen patients and they come back and they've had a successful surgery. I look at their pathology report. I've talked to their doctors. They've had excision. Why are they still in pain? A lot of doctors are just focused on the surgery and removing the lesions, but they haven't addressed the central nervous system. They haven't addressed the gut dysbiosis. They haven't addressed the pelvic floor physical therapy. And so there's still pain generators, even though the constant inflammatory generator is now removed, which is important. These other things are still in place that haven't been treated. So, physical therapy. So in physical therapy, we're addressing musculoskeletal impairment. So hypertonic muscles, connective tissue restrictions, myofascial restrictions, neural tension, body alignment. So if you think of how, when you're in pain, abdominal pain, or like period cramps, you're bent over and hunched over, your abdomen's shortening. When you do that, it changes the position of your pelvis. That can promote more tension in the pelvic floor muscles, or maybe stretch certain tissues that shouldn't be stretched. And this is probably happening for many, many years of your life. And so you create, or your body creates, trigger points and fascial restrictions that need to be addressed. So we help to improve posture and body mechanics, improve motor control deficits involving the core and the pelvic floor muscles. We create individualized home programs for people. And then we also are a wealth of knowledge of the people that are around us that treat these disorders. We work with OBGYNs and urologists and pain psychologists or acupuncture or functional medicine. And we have so much information that when you're, at home and looking online, it's so much and it's so overwhelming. So we really work as sort of case managers to help you dig through, like, what's the priority, what's important. We provide education and resources for you. So your physical therapist can do quite a bit. So what does a treatment session look like? So we actually have a blog called What a Good Treatment Session Is Like. And not all pelvic floor PT is the same. And we want to make sure that you're getting the adequate treatment and you know what you should be getting. So, when you come in for your first visit, it's important that you either fill out paperwork or you have a conversation with your therapist. You get to know you and your story. You go through the different systems and you help, and the PT helps to identify, like, what are all the pain generators that are potentially causing your symptoms. And they do this by talking to you, hearing your story, and also the physical exam. So the hands-on portion of the exam can say, hey, there's this trigger point and that's reproducing your urinary urgency. Or, hey, deep in here, there's a lot of tightness and fascial restrictions. This is probably part of why you're having pain with deep penetration when you're having intercourse. Or, hey, we did the exam, you've been on oral contraceptives for 10 years and there's a lot of redness and this Q-tip is really painful. Let's get you to see a provider that you can help fix that. So we really find all those problems and we prioritize them. What's going to make you feel better faster? Here's what we can do. And it's not something that maybe it has to be addressed right away, but at some point it's probably going to be part of your plan. Then you should receive education on your diagnosis or the treatment options, given resources. If you need to be seen by another provider, like, who is that? What are they going to do for that? And then make a plan. So you want to make short-term and long-term goals. In 6 weeks, we're going to work on this and you're going to hopefully see these improvements. And then that's going to lead to these longer term. You're going to have less pain with intercourse. You're going to have normal urinary frequency and urgency. You're not going to get up in the bathroom to go to the bathroom multiple times a night. Your pain should be reduced this amount with during your cycle, things like that. Diet. So, in PT, diet is in our scope of practice to talk about. And there's a lot of controversy about diets and which one is right. I'm actually finishing up my master's program in an integrative health and nutrition program. And so we talk a lot about diets, and because it's an integrative program, they're really looking at more of root causes of issues. And so that's how we develop our programs. This is a great book that a friend of mine actually just wrote, Katie Edmonds. She is on social media as heal.endo on Instagram, and she works with patients to create diet plans that work for them. And she recognizes that one diet doesn't work for everybody. So I just wanted to touch on a few of the common diets that people may hear about when discussing endo. So the anti-inflammatory, paleo, keto, the IC diet, gluten-free diet, low FODMAP, or vegan and plant-based. So in general, you have to remember that endo is an inflammatory condition. Also thinking about IC and IBS. So anti-inflammatory diets are going to really, this can maybe be an elimination diet too. So the high inflammatory foods, this is going to be your gluten and wheat, your dairy, sugar, soy, corn, sometimes eggs. And so you take all this out and you let your body kind of calm down. Now, all of these things, they generally induce inflammation. Some people may not be as reactive as others. Paleo and keto diet are more on the low carbohydrates. There are some differences between the two, and there's some diets that kind of mix the two. Paleo is, you can have more carbohydrates, but more in the form of vegetables, not like breads and starches. Whereas keto is truly, it's a very low amount of carbohydrates, usually less than 20 grams per day. Whereas paleo, I think you can actually, or low carb, that's in the literature, it can be less than like 120 grams of carbs a day. But both of these are really looking at blood sugar regulation and insulin. Sugar is inflammatory, and these work great for some people. The IC diet, because of the overlap of interstitial cystitis, a lot of people are given the IC diet. Now, for me, I have some of my own reservations about this, but this is based on high potassium foods. And it's not necessarily going to address the inflammation component, but if somebody is really reactive to like histamines and potassium, this diet might, or citric foods, high acid foods, they may benefit from that. However, because it's not really coming from the bladder, a lot of this, I tend to start my patients more on an anti-inflammatory. And if they notice that things like salad dressings or lemon or orange or coffee really aggravates, then I'll just have them remove that too. But I don't quite start on the ICA diet. If you look at the standard IC diet, it's like white bread and crackers and pretzels. And you kind of think, well, that's not really healthy. But that's because the diet was developed for people with true IC, where it's actually coming from the bladder. Gluten-free can be great for some. That kind of goes back into the anti-inflammatory. Low FODMAP I use a lot. So one of the things I didn't really get into, and this can be a whole nother topic, is SIBO, which is small intestine bacterial overgrowth. And so many people suffer from this condition. It's often one of the main causes of IBS symptoms. And this is kind of going back to like specific carbohydrates. So you have an overgrowth of bacteria in the gut that's creating hypersensitivity in the nervous system, abdominal bloating. So two very similar things as endo. And what it's doing is you're consuming what you actually is pretty healthy food. So like it might be starchy vegetables or garlic or onions, and you're getting all this bloating and gas and abdominal pain. So low FODMAP is used for those who have SIBO. It also has been shown to be very effective in those with IBS, usually because SIBO is a huge cause of IBS. And then vegan and plant-based, there's a lot of questions, like there's people that link, red meat to endo symptoms, but I think, again, working with somebody that is looking at your individual diet plan is really important. Vegan doesn't always mean healthy. And so that's, I think, something that people don't quite understand. But also, vegan diets are going to contain a good amount of soy to get your protein. And I think it's important to know that high soy, especially if it's GMO, which a lot of it is going to be, it's going to mimic estrogen in your body. And so that may not be the best, but it may work for some. The other note I want to make about diet is supplements. So if you've been on oral contraceptives, or if you still are, or you had been for a long time, there is or can be issues with the gut. And so there are some supplements that you may want to take regarding that. And that will be included. I'm going to make a reference sheet. And I did write a blog about that. And it talks about what supplements are really important to supplement with if you're on oral contraceptives. But one really great, and I love using this, is magnesium glycinate. Most people are magnesium deficient in general. And what with cramping and period pain, it's a smooth muscle contraction, and magnesium is really, really good at calming down smooth muscle contractions. Aviva Ram, she's an MD, a medical doctor, but she does more functional and women integrative medicine, and she focuses on women's health. She has a really great blog about magnesium and why women need it in particular. So how do you find a medical provider that can help you, like a pelvic floor physical therapist? You can check out all of these different sites to find somebody that's close to you that can help you. Call them, ask them if they see, women with endometriosis. Most of us do. And so getting into seeing somebody locally is going to be really helpful in your care. Some resources in general, there's a Facebook group called Nancy's Nook that provides a lot of educational materials. This group really really helps you to become an advocate for yourself, to look up doctors that are approved. So excision specialists only. And new doctors are being added to the group daily. They're looked at, like, do they do excision? What's the experience been? What do people say? It really isn't a support group, though. It's really a platform to find good education. Endo What is a film that was created by a woman who has endometriosis, and she, I believe, is having another film coming out relatively soon, but it provides a lot of education about what endo is and what endo is not. And they are doing the school nurse initiative, where for every copy purchased, a school nurse's office is getting the video plus some resources to help provide and promote education about endo, starting at like an adolescent age. You have the endo.co and endofound.org. Endofound.org is the Endometriosis Foundation of America, and the endo.co is run by women who have endo. And it's both of those sites are really good for getting good information about endo, what's going on in the endo world, medications, research, resources. And then a couple books recently, Dr. Iris Orbuck and Amy Stein, who is a physical therapist in New York, put out Beating Endo. And then a previous book also by a doctor in New York is The Doctor Will See You Now. So both are great resources. And then I found that the endometriosis podcast, if you look at podcasts, I found this to be a really good informational source that looked at the different research and some of the things regarding surgery. It's hosted by a endo surgeon in Portland, Oregon, and they, I think, are attempting to do bi-monthly podcasts. So please, for everybody who is joining, you can actually get you can enter yourself in to win a copy of Pelvic Pain Explained, a book that Stephanie and Liz wrote a few years back. It's a great resource, and it really talks a lot about the mechanisms of pelvic pain and is a great resource if you're experiencing pelvic pain. So if you go to our website and you scroll to the bottom of the homepage, you can fill that out and enter to win a copy. So to hear more about pelvic health in general, follow our blog, pelvicpainrehab.com. Or you can find it at pelvicpainrehab.com. And like I said, the resources that I talked about will be included and posted as a blog post. You can get those emailed to you. Follow us on Facebook and also Instagram. We're doing a lot of Instagram TV. So if you like these webinars, this one was kind of long and I apologize. There's so much about endo, but we're doing different clips on different things all related to pelvic health, treatments and information. So follow us there and keep up to date. If anybody has questions, we didn't get a ton before we did this webinar. A lot of people, I think, wanted to know about it. But if you have any questions, please post, and we can do another webinar to specifically address any questions you have after listening to this. So thank you very much, and I hope you got a lot out of this.